Welcome to the Deep Dive. Today we're tackling a health issue that's surprisingly common and really important to understand, gastric ulcers.
Yeah, definitely.
Think of this as your shortcut, maybe, to getting a solid grasp on those sores that can pop up in your stomach lining.
Exactly. It's a type of peptic ulcer, and understanding them really boils down to appreciating delicate balance between stomach acid and how our bodies, protect themselves.
Okay, and for this deep dive, you've looked at a whole range of sources, right, to get a comprehensive view.
We have, yes. The goal is really to pull out the most crucial information about gastric ulcers for you. Make it clear, understandable, and hopefully memorable.
Excellent. Okay, let's unpack this then. What exactly is a gastric ulcer, in plain terms?
Well, picture the inside of your stomach having this protective layer, right? The mucosa. A gastric ulcer is basically a break in that lining.
Just a break.
Well, it's a bit deeper and wider than just a superficial scratch. Officially, it's defined as being a larger than 5 millimeters in diameter, and it has to reach down into the layer beneath the mucosa, which is called the sub-mucosa.
Got it. So deeper than just the surface layer.
Yeah.
And it's one type of peptic ulcer.
Precisely. The other main type you hear about is a duodenal ulcer. That happens in the first part of your small intestine, the duodenum, just after the stomach.
Okay. So what's the underlying cause here? What actually sets the stage for these ulcers to form?
Fundamentally, it's an imbalance between the stomach acid, which we need for digestion, obviously, and the protective mechanisms that are supposed to keep that acid from, well, harming the stomach itself.
Like the stomach's own defense system.
Exactly like that. Think of it as having shields up. When those shields get weakened, or the attack from the acid gets too strong, the acid can start to erode the stomach tissue, and that leads to an ulcer.
Okay, makes sense. So what are the main things that can disrupt this balance? What weakens the shields?
The number one troublemaker is a type of bacteria called Helicobacter pylori, H. pylori for short.
Yes, H. pylori. Heard of that one.
It's a real survivor. It can actually live in that really harsh acidic environment inside the stomach. And the problem is it damages the protective mucus layer.
How so?
Well, that mucus layer normally acts as a physical barrier between the stomach lining and the acid. H. pylori disrupts it, making the lining vulnerable.
Right. Definitely not a friendly visitor then. What else can upset this balance, aside from H. pylori?
Another major factor is the regular use of non-steroidal anti-inflammatory drugs, NSAIDs.
Like aspirin, ibuprofen.
Exactly those. Things like aspirin, ibuprofen. Taking them regularly is a big risk factor because they interfere with the production of something called prostaglandins.
Prostaglandins, what do they do?
Think of them as sort of hormone-like substances that play a key role in protecting the stomach lining. They help maintain the mucus layer, ensure good blood flow, and regulate acid. NSAIDs reduce these prostaglandins.
I see. So fewer prostaglandins means the stomach's defenses are weaker, more vulnerable to the acid.
Precisely.
Are there any other contributing factors we should know about, beyond H. pylori and NSAIDs?
Yes, while those are definitely the big players, other things can contribute. Things like excessive alcohol consumption, smoking, maybe high levels of stress.
Stress? Really?
It's thought to play a role, possibly by affecting acid production or blood flow. Also, taking steroid medications and having certain other underlying medical conditions can increase the risk too.
Okay, so putting it all together, who is most likely to actually develop a gastric ulcer? Let's talk risk factors.
Well, the major risk factors really echo the causes we just discussed. So having an H. pylori infection is a really significant one.
Makes sense.
And regular, especially long-term, use of NSAIDs, that greatly increases your risk.
Right.
And unfortunately, just getting older is a risk factor too, partly because the stomach lining's protective abilities can naturally decline a bit with age, and also because older individuals tend to use more NSAIDs for things like arthritis.
What about lifestyle choices? Do they play a big part? You mentioned alcohol and smoking.
Absolutely. Excessive alcohol intake and smoking are definitely clear risk factors.
Yeah.
High stress levels, as we mentioned, are also considered a factor.
And other medical conditions?
Yes, certain conditions affecting the liver, kidneys, or lungs can increase susceptibility. And finally, if you have a family history of ulcers or maybe gastrointestinal bleeding, that might suggest a genetic predisposition.
Interesting. No, I've also heard about silent ulcers. What are those, and are there specific risks for them?
Yeah, silent ulcers are basically ulcers that don't cause those typical noticeable stomach pain symptoms. They can be quite dangerous because they might only be discovered when a complication occurs, like bleeding.
Who gets those?
The risk factors seem to include older age again, being male, smoking, having an H. pylori infection, and perhaps surprisingly, the absence of something called atrophic gastritis.
What's atrophic gastritis?
It's a condition where the stomach lining itself becomes thin and less effective, so it's a bit counterintuitive. And silent ulcers seem to be more common in some populations, like in Korea, possibly linked to higher rates of H. pylori there.
Okay, so we know the causes, the risks. Let's get into the nitty-gritty, what's actually happening inside the stomach when an ulcer forms, the pathophysiology.
Right, so the core mechanism, as we keep saying, is that imbalance. The protective factors just aren't strong enough to counteract the damaging effects of the stomach acid and digestive enzymes like pepsin.
And those protective factors are mainly the mucus.
Exactly. Normally, the stomach lining produces a thick layer of mucus, and it also secretes bicarbonate, which helps neutralize the acid right at the surface of the cells, like a double defense system.
A physical barrier and a chemical neutralizer.
You got it, like a security blanket and a built-in antacid rolled into one. But when these mechanisms are weakened, maybe H. pylori is disrupting the mucus, or NSAIDs are reducing prostaglandin production.
Which affects the mucus and bicarbonate and maybe blood flow too.
Precisely. Reduced blood flow also impairs healing. So when that protection is compromised, the acid can penetrate the lining and start to erode the underlying tissue. That erosion process is what forms the ulcer.
Got it. So if someone comes in with stomach pain, indigestion, how do doctors tell if it's a gastric ulcer versus something else? What's the differential diagnosis look like?
That's a really crucial question because the symptoms, often lumped together as dyspepsia, can overlap with loads of other conditions. Doctors have to cast quite a wide net initially.
What sort of things are on that list?
Well, you have to consider serious things first, even if rare, like an abdominal aortic aneurysm rupture presenting with pain. Much more commonly, though, you'd think about gastroesophageal reflux disease, or GRD, that's heartburn, essentially.
Okay.
Then there's the possibility of a duodenal ulcer, which we mentioned similar symptoms, different location. Gallbladder problems like gallstones causing biliary colic can mimic ulcer pain. Chronic pancreatitis, Crohn's disease, diverticular disease, though, that's usually lower down, and even irritable bowel syndrome, IBS, can sometimes cause upper abdominal discomfort.
Wow.
Also, simple drug-induced dyspepsia from other medications. Less commonly, things like hepatitis or acute stress ulcers from severe illness, or Zollinger-Ellison syndrome.
Zollinger-Ellison, what's that?
That's a rare condition where tumors cause the stomach to produce massive amounts of acid. You'd suspect it especially if ulcers keep coming back despite treatment, or if someone tests negative for H. pylori. And even, sometimes coronary heart disease can present with atypical pain that feels like indigestion.
So it's really not straightforward sometimes. A lot to rule out.
Definitely requires careful evaluation.
Okay, so how common are gastric ulcers these days? What's the epidemiology look like? Are we seeing more or less of them?
Thankfully, the overall trend, certainly in developed countries, is a decline in gastric ulcers, and that's largely thanks to better detection and effective treatment for H. pylori.
That's good news.
It is. In the UK, for instance, the prevalence of H. pylori is estimated to be around 25%, though it's often higher in older age groups and in people from lower socioeconomic backgrounds.
And what about general indigestion symptoms? How common are they?
Pretty common. Around 40% of adults experience dyspepsia each year, which is quite high. This leads to about 5% of people seeing their primary care doctor for it, and maybe 1% ending up having an endoscopy to investigate.
And who tends to get the actual ulcers more?
Gastric ulcers specifically are still more common in older adults and seem to affect men slightly more often than women, although that gap might be closing.
So globally, things are generally improving.
Yes, overall peptic ulcer rates that includes both gastric and duodenal are decreasing worldwide, mostly because the H. pylori-related ones are becoming less frequent, though you might see higher rates in certain immigrant populations where H. pylori is still more prevalent.
Interesting.
And historically, duodenal ulcers used to be much more common in men, maybe a 3.2 ratio, but that's become much more even now, again, likely due to better H. pylori control.
And just to put it in perspective, if someone does get an endoscopy for dyspepsia, what are the chances it's actually an ulcer?
Good question. The data suggests that in patients undergoing endoscopy for dyspepsia, About 40% turn out to have functional dyspepsia, meaning no clear structural cause is found. Another 40% or so have GRD. Ulcers, both gastric and duodenal, account for maybe 13%. Then you have smaller percentages for gastric cancer, around 2%, and esophageal cancer, about 1%.
Okay, that gives a good sense of the landscape. So if someone suspects they might have a gastric ulcer, how does it typically present? What are the key clinical features?
Well, the symptoms can be quite variable, and it's really important to remember what we said about silent ulcers. Some people might not have any obvious symptoms at all.
Right. But for those who do.
The classic symptom is abdominal pain, usually in the upper abdomen, the epigastrium. It's often described as a burning or gnawing or maybe aching sensation.
Okay. And is there anything about when the pain happens that's characteristic?
Yes, the timing in relation to meals can be a useful clue. With gastric ulcers, the pain often gets worse when the stomach is empty, and it might actually feel better soon after eating.
Better after eating. That seems counterintuitive.
It does, but the food might buffer the acid temporarily or stimulate bicarbonate release. This pattern is often contrasted with duodenal ulcers, where the pain tends to worsen an hour or two after eating when the stomach empties acid into the duodenum.
Ah, okay. That's a key differentiator then. What other symptoms might someone experience?
Nausea is common, sometimes vomiting, and if it's severe or complicated, the vomit might contain blood, which looks like coffee grounds, or it could be bright red. That's hematemesis. Bloating, heartburn, a loss of appetite, and sometimes unintended weight loss can also occur. Fatigue, too, especially if there's chronic slow bleeding leading to anemia.
And severe cases.
In severe cases, as we mentioned, you can get major complications like significant gastrointestinal bleeding, perforation where the ulcer eats right through the stomach wall, or obstruction where scarring blocks food from leaving the stomach.
Are there any other specific signs or symptoms to listen for?
Sometimes the pain might wake someone up at night. It can occasionally radiate through to the back. And finding that taking antacids provides temporary relief is also pretty suggestive.
What about during a physical exam? Would a doctor find anything?
Often, in uncomplicated cases, the physical exam might be completely normal, but the doctor might find some tenderness when they press gently on the upper abdomen over the stomach area.
Any other signs?
In rarer cases, if there's significant delay in the stomach emptying, perhaps due to scarring near the outlet, the doctor might hear something called a succussion splash, basically a sloshing sound when they gently shake the patient's abdomen.
Interesting.
But really, the diagnosis relies heavily on the patient's history, considering the symptoms and risk factors, and then confirming things with investigations, primarily endoscopy.
Okay, let's move on to investigations then. If a doctor suspects a gastric ulcer, what tests are usually done?
The mainstays are checking for H. pylori and getting a direct look at the stomach lining. So first off, a Helicobacter pylori test.
How's that done?
Usually with either a urea breath test or a stool antigen test. These are non-invasive and pretty accurate, especially recommended for patients under 55 without worrying symptoms. A positive result points strongly towards H. pylori being involved.
And the direct look.
That's the upper gastrointestinal endoscopy, sometimes called a gastroscopy or OGD. This is really the gold standard, the most specific and sensitive test.
Why is it so good?
Because it allows the doctor to use a thin, flexible camera to actually see the inside of the esophagus, stomach, and duodenum. They can spot ulcers, assess their size and appearance, and crucially, take biopsies.
Biopsies, why are they needed?
For a couple of reasons. They can test the biopsy tissue for H. pylori directly. That's called a CLO test sometimes. And very importantly, especially with gastric ulcers, they need to take biopsies to rule out malignancy. Stomach cancer can sometimes look like an ulcer.
Right, that's critical.
Oh.
Any other initial tests?
A full blood count, an FBC, is often done, especially if there's any suspicion of anemia. Maybe the patient looks pale, feels tired, or there's a history of bleeding. Microcytic anemia, meaning small red blood cells, can suggest chronic iron loss from a slowly bleeding ulcer.
You mentioned different H. pylori tests. Any nuances there?
Yeah, besides the initial urea breath test or stool antigen test, there's a specific type called the carbon-13 urea breath test, which is often preferred for retesting after treatment to confirm eradication. There are also lab-based blood tests, serology, that look for antibodies, but their accuracy can vary, and they can stay positive even after the infection is gone, so they're less useful for confirming cure. Simple office-based near-patient serology tests aren't generally recommended for initial diagnosis.
Okay. And you touched on endoscopy guidelines. When is an endoscopy definitely warranted?
The NICE guidelines in the UK give a pretty clear framework. Basically, for younger patients, say under 55, without any alarm features, you might try treating symptoms first without an immediate endoscopy.
What are these alarm features?
These are red flags that suggest something more serious might be going on. They include things like iron deficiency anemia, signs of chronic blood loss like melena, unexplained weight loss, progressive difficulty swallowing, dysphagia, persistent vomiting, or finding a palpable lump in the upper abdomen during an exam.
So if someone has any of those, they need an endoscopy regardless of age.
Yes, pretty much. And for patients who are older, say over 55, even without those specific alarm signs, doctors should have a lower threshold for considering endoscopy, especially if they have a history of previous ulcers, stomach surgery, pernicious anemia, if they're regular NSAID users, or have a family history of stomach cancer.
Makes sense to be cautious. Do other imaging tests like x-rays play much of a role?
Not usually for the initial diagnosis of the ulcer itself. Upper endoscopy provides that direct visualization, which is far superior. X-rays like a barium meal used to be used more, but they're much less sensitive and don't allow for biopsies.
So endoscopy and H. pylori testing are the core investigations.
Exactly, along with blood tests like the FBC if needed. It's about putting all the pieces together for an accurate diagnosis and ruling out other possibilities.
Okay, diagnosis made. Let's talk treatment. What's the overall management approach for a gastric ulcer?
The general strategy is multi-pronged. You want to, first, treat the underlying cause if you've identified one. Second, relieve the patient's symptoms. Third, promote the actual healing of the ulcer crater. And fourth, prevent complications or recurrence down the line.
And how do we achieve that?
It usually involves a combination of medications and important lifestyle adjustments. And in some specific situations, particularly if there are complications like bleeding, endoscopic procedures, or even surgery might come into play.
Okay, let's grip down the medications first. What are the main classes of drugs used?
The real workhorses are the acid-suppressing medications. Primarily, the proton pump inhibitors, or PPIs, names like omeprazole, lansoprazole. They're very effective at reducing stomach acid production.
Any others?
There are also H2 receptor antagonists, like ranitidine used to be, though others are available. They also reduce acid, but generally they're considered less potent than PPIs for ulcer healing.
Right.
Then, critically, if H. pylori infection is confirmed, a course of antibiotics is absolutely essential to eradicate the bacteria. And sometimes doctors might add cytoprotective agents, drugs that help bolster the stomach's natural defenses, although they're used less commonly now with the effectiveness of PPIs.
Okay. And what about those lifestyle changes you mentioned? What should patients be doing?
Avoiding NSAIDs, if at all possible, is a big one. If they have to take them, it needs careful discussion about risks and maybe co-prescribing a PPI. Reducing alcohol intake is also advised, as is quitting smoking. Smoking definitely impairs ulcer healing and increases recurrence risk.
What about stress and diet?
Managing stress is generally good advice, though its direct impact on ulcer healing is maybe less clear-cut than stopping NSAIDs or smoking. As for diet, there aren't really specific foods to absolutely avoid, but a generally healthy diet is sensible. Some people find certain foods trigger their symptoms, so obviously they'd avoid those.
Okay, let's get more specific on the prescribing side. What's the typical first-line treatment plan?
So the goal again is treat complications, get rid of the cause, relieve symptoms, heal the ulcer. A key first step, if relevant, is to stop any potentially contributing medications, especially NSAIDs, assuming it's safe to do so from the perspective of why they were taking them.
Makes sense.
Then what? Then it depends on the H. pylori status. If H. pylori is present, the standard approach is triple therapy.
Triple therapy.
Yes, it usually involves taking 3 drugs together for a week or 2. Typically, it's a PPI plus 2 antibiotics. The common combination is clarithromycin and either amoxicillin or, if there's a penicillin allergy, metronidazole.
Is there an easy way to remember that combination?
Yeah, a popular mnemonic, especially for revision, is Pac-Man eats H. pylori. P for PPI, A for amoxicillin, or metronidazole, and C for clarithromycin.
Pac-Man. I like it. Okay, what if H. pylori isn't the cause? Or the test is negative?
If H. pylori is absent, then the first-line treatment is generally just a PPI on its own, usually for 4 to 8 weeks, to reduce acid and allow the ulcer to heal.
And if PPIs don't work or aren't suitable?
Then an H2 receptor antagonist might be tried as a second-line option. And specifically for ulcers that are clearly caused by NSAIDs, sometimes a drug called misoprostol might be considered. It's a synthetic prostaglandin that helps protect the lining, but it can have side effects like diarrhea.
Okay. Now, what about more urgent situations? You mentioned bleeding ulcers earlier. How are they handled?
Right, an actively bleeding ulcer is a medical emergency and usually requires prompt upper endoscopy. During the procedure, the endoscopist can identify the bleeding point and attempt to stop it.
How do they stop it?
They have several techniques. They might inject adrenaline around the bleeding vessel to constrict it, use heat cautery to seal it, or apply tiny metal clips to clamp the vessel shut. Often a combination is used.
If that doesn't work.
If endoscopic treatment fails or the bleeding is too severe, the next steps might involve interventional radiology doing a procedure called embolization to block the feeding artery, or in some cases, surgery might be required to control the bleeding.
And lifestyle factors are still important, even with bleeding.
Absolutely. Regardless of how the bleeding is stopped, addressing the underlying cause, like treating H. pylori or stopping NSAIDs, and advising on smoking cessation and reducing alcohol are crucial for preventing rebleeding or recurrence.
You mentioned behavior modification as part of management. Can you expand on that?
Sure, it overlaps with lifestyle, but it's about actively changing behaviors that contribute to the problem. So if a drug is identified as the cause, stopping it, if feasible, is the key behavioral change. Strongly advising and supporting smoking cessation is another major one.
Anything else?
It also involves educating patients on how to take other medications correctly, especially ones that can irritate the stomach, like bisphosphonates such as alendronate for osteoporosis. They need to be taken with plenty of water while upright. Or if someone must continue NSAIDs, understanding the risks and maybe taking a PPI alongside it for protection. Adherence is key.
Okay. So let's talk about the healing process itself. How does treatment actually make the ulcer heal?
Well, if the ulcer is H. pylori positive, the most critical factor for healing and preventing recurrence is successfully eradicating that bacteria with the antibiotic regimen. Removing the primary aggressor allows the natural healing processes to take over, aided by the acid suppression from the PPI.
And if it's H. pylori negative but caused by NSAIDs?
Then the key is stopping the NSAI, if possible. Healing is then usually achieved effectively with a course of PPIs. Studies show PPIs are generally more effective than H2 antagonists for healing NSAID-induced ulcers.
What if it's negative for H. pylori and not caused by NSAIDs?
That scenario is actually quite rare. If someone has an ulcer with no H. pylori and no NSAID use, doctors need to dig deeper. Recheck the drug history carefully. Consider less common causes like Zollinger-Ellison syndrome, Crohn's disease affecting the stomach, or even malignancy.
Right. And for bleeding ulcers, the priority is stopping the bleed first.
Yes, hemostasis through early endoscopic intervention is the priority for bleeding ulcers, followed by treating the underlying cause to promote healing and prevent rebleeding.
How do we prevent these ulcers from coming back? What about recurrence?
For H. pylori-related ulcers, again, successful eradication is the cornerstone of prevention. It dramatically reduces the risk of the ulcer returning. Usually an endoscopy is repeated after treatment, especially for gastric ulcers, to confirm healing and double-check there was no underlying malignancy missed.
How do you confirm eradication?
Usually with a urea breath test or stool antigen test performed at least 4 weeks after finishing antibiotics and 2 weeks after stopping PPIs, as these can interfere with the test results. Serology blood tests aren't reliable for confirming eradication because the antibodies can linger for a long time.
What about people needing long-term NSAIDs?
For patients starting long-term NSAID therapy, it's generally recommended to test for and treat H. pylori beforehand if it's present, as this reduces their risk of developing an ulcer. For those who do develop recurrent symptoms or ulcers despite treatment, sometimes intermittent courses of PPIs or even long-term maintenance therapy might be considered, usually with an annual review.
How are patients monitored after their initial treatment?
Typically, they'll be reviewed at the end of the treatment course, particularly after H. pylori eradication therapy, to see if their symptoms have resolved. A repeat endoscopy isn't always needed if symptoms clear up completely, unless it was a gastric ulcer, which always needs confirmation of healing due to the small cancer risk, or if symptoms persist or recur quickly. Confirmation of H. pylori eradication is also important.
Do we have solid data on how effective these treatments are, like numbers?
Yes, there's quite a bit of evidence. For example, looking at duodenal ulcers, Acid suppression therapy alone heals a good percentage, maybe around 69%, but adding H. pylori eradication therapy significantly improves healing and dramatically reduces relapse.
So much does it reduce relapse?
Studies have shown relapse rates for duodenal ulcers dropping from around 39% with just acid suppression to maybe 9% or even lower with successful H. pylori eradication. That's a huge difference, a number needed to treat NNT of around 2 or 3 to prevent one relapse.
Wow. And for gastric ulcers?
Similar benefits are seen, maybe slightly less dramatic, but still very significant reductions in relapse with eradication therapy. And for NSAID users, eradicating H. pylori has been shown to roughly half the risk of developing endoscopic ulcers over a 6-month period, maybe from 18% down to 9%.
So the data really backs up targeting H. pylori.
Absolutely. It underscores how crucial identifying and treating that infection is in the overall management of peptic ulcer disease.
That's really clear. So wrapping up the treatment side, what's the overall outlook? What's the prognosis typically like for someone diagnosed with a gastric ulcer?
Generally speaking, the prognosis is actually quite good, provided the underlying cause is identified and treated appropriately.
So most people get better.
Yes, the vast majority of gastric ulcers will heal completely with the right combination of medication, like PPIs and H. pylori eradication if needed, plus relevant lifestyle changes like stopping NSAIDs or smoking.
Does the outcome depend on the cause?
It does. The long-term outcome really depends on what caused the ulcer, whether any complications developed, and how well the patient adheres to and responds to the treatment. For example, successfully eradicating H. pylori usually leads to a very low recurrence rate. If someone has to continue NSAIDs, the risk might remain higher unless protective measures are taken.
But complications can be serious.
Absolutely. Complications like major bleeding or perforation are serious and can even be life-threatening if not managed promptly. That's why timely diagnosis and effective management are so important. But with that in place, the overall prognosis is favorable for most people, and the risk of those serious complications is significantly reduced.
Okay, let's touch on those complications properly then.
Yeah.
What are the main ones we need to be aware of with gastric ulcers?
The most common serious complication is definitely gastrointestinal bleeding.
How does that show up?
It can present as vomiting blood, that hematemesis we mentioned, which might look like coffee grounds or be bright red, or as passing black, tarry stools, which is called melena. That black color is from digested blood.
Is there a memory tip for melena?
Yeah, just think black like old blood or black like tar. It's quite distinctive.
Okay. What's the next most common complication after bleeding?
That would likely be perforation. This
Wow.
is where the ulcer erodes completely through the entire thickness of the stomach wall.
Ouch. What happens then?
Stomach contents, acid, food, bacteria leak out into the abdominal cavity. This causes sudden severe abdominal pain and leads to peritonitis, which is a widespread, dangerous inflammation and infection of the abdominal lining. It's a surgical emergency.
That sounds incredibly serious. Any others?
Yes. Another potential complication is gastric outlet obstruction. This tends to happen more with ulcers located near the exit of the stomach, the pylorus. Repeated inflammation and scarring from the ulcer can narrow this opening.
What are the symptoms of obstruction?
People might feel full very quickly when eating, experience significant bloating, persistent nausea, and frequent vomiting, often of undigested food eaten hours before. This can lead to dehydration and weight loss.
And you mentioned a link to cancer.
Yes, while most gastric ulcers are benign, there is a small but important risk, particularly with ulcers in the stomach itself, less so duodenal, that what looks like an ulcer could actually be an early gastric cancer, or that chronic inflammation associated with H. pylori could eventually, over many years, increase the risk of developing gastric cancer. That's why biopsies are so crucial during endoscopy for gastric ulcers, and why follow-up endoscopy to confirm healing is often recommended.
Got it. So bleeding, perforation, obstruction, and that small malignancy risk really highlights why getting treatment is so vital.
Exactly. Timely and appropriate management is key, not just for healing the ulcer, but for preventing these potentially very serious outcomes.
Well, that has been an incredibly thorough deep dive into gastric ulcers. Really comprehensive. Let's try and quickly recap some of the absolute key takeaways for everyone listening.
Sure. So we've defined a gastric ulcer as that open sore, deeper than the mucosa in the stomach lining. We've really hammered home the main causes: number 1, H. pylori infection, and number 2, regular NSAID use. That imbalance is key.
Right. And the symptoms can vary hugely, from that classic burning pain that might improve with eating, right through to being completely asymptomatic or presenting with serious bleeding.
Exactly. And for diagnosis, endoscopy is really the gold standard investigation, allowing visualization and those crucial biopsies. H. pylori testing is also fundamental.
And when it comes to management, the absolute cornerstone is treating the underlying cause, getting rid of H. pylori with triple therapy, remember, Pac-Man, stopping NSAIDs if possible, and using PPIs to suppress acid and allow healing.
Couldn't have said it better. Addressing the cause is paramount for both healing and preventing recurrence.
And recognizing those risk factors, age, smoking, alcohol, family history, and seeking timely medical attention if you have concerning symptoms like persistent pain, weight loss, or signs of bleeding is just so important.
Absolutely crucial.
Okay, so here's a final thought, perhaps, for you listening. We've talked about declining rates due to H. pylori treatment, but gastric ulcers are still pretty common. Considering how well we understand them now, what role do you think ongoing lifestyle factors, maybe diet, stress, medication use in our modern world, continue to play in their persistence? Something to mull over.
Definitely food for thought.
And if you want to really consolidate this knowledge, especially for MSRA revision or test yourself, definitely check out PathMSRA.com.
And for more free revision resources and questions, head over to freemsri.com.
Brilliant. Thanks again for diving deep with us today.